I want to get a little bit even more granular, right? So what is a bed sore?
A bed sore is a area of dead tissue caused by pressure. So the muscle dies first if a person is not reliably turned. If the muscle dies, then the skin will die because it loses its blood supply, which comes from the muscle. And over 2 to 4 weeks' time, that skin will become dead. And eventually you could put your fist in or 2 fingers into the wound because it's a serious injury. Good morning. I'm Dr. Vigna. I'm here with Ben Martin, and we're going to talk about bed sores. So, Ben, you've sued on pretty much any type of serious personal injury, pharmaceutical injury, medical malpractice, 18-wheeler injuries, paraplegia. What is it about bed sores? You have a lot of bed sore clients, so tell us why you're in this litigation.
I've represented people for many, many years, decades, who have had experience with a bed sore, right? But at some point, it was happening so often that it just, to me, was becoming an epidemic. And so then I looked at the specifics of why is this happening? And we got involved together in looking at bed sore cases. And you from the medical aspect of it, and both of us from the legal aspect of it. And it really did seem to me that it was becoming an epidemic. I hadn't remembered bed sores being such a problem 20 years ago, 30 years ago. Why is it becoming such a problem now? Tons of people, many people are getting these bed sores in hospitals and nursing homes.
Hospitals are supposed to be safe places.
It made no sense to me.
All bed sores are bad injuries, and stage 3, stage 4, they're all preventable, and someone is making a profit on providing bad care.
Right.
What's your thoughts on hospital-acquired bed sores?
Okay, so that's really what got me back into looking at bed sores and bed sore cases across the country, because I was really shocked that hospitals were over and over again causing these bed sores.
Tell us about never events and what that means to a lawyer and prosecuting a case.
So there's a specific meaning for the term never event. And never event, and you can correct me on this, Greg, because you're as much of an expert or more than I am.
I'm more of an expert than you are.
I see never events as something that Medicare and the federal government say, we're not going to pay for anything related to a bed sore. Once you create a bed sore, you're a hospital, you create a bed sore, we ain't paying for it because it's a never event. It should never happen.
And
am I right?
Yeah, exactly. And they go one step farther, that it tends to indicate that the quality of care is bad. And if a hospital causes a bed sore, whatever care that bed sore required in that hospital going forward, they would be responsible for that cost. But that doesn't prevent a hospital to simply discharge that person who they seriously injured to a nursing home or another hospital, and they won't get billed with it. So what's your thoughts on that?
So that's another tragedy that we've seen that occurs, is that a hospital will create this never event, right? It's never supposed to happen. You're never supposed to, a patient should never have a bed sore, should never develop a bed sore in a hospital. And the reason is that they're always preventable.
I'm going to interrupt. There's one tiny little sliver that may contribute substantially to bed sores, but I have never seen that with my own eyes. If a person has septic shock and have profound hypotension that they can't support their own blood pressure, there can be the development of pressure because the person just can't supply their tissues. When I've been in that situation, that patients are profoundly sick and they can't be turned, and I put them on a clinitron, and I've never seen this entity, but but it's described in the literature, and if there's sustained and ongoing hypotension, that may be causative, and that's why we have experts involved in each case to understand how this occurred.
So
Tiny
if I'm
little slip.
understanding from your perspective, Greg, as a doctor, and by the way, you've treated what, hundreds of patients
Yeah.
who are in a hospital setting that have developed bed sores?
Well, they were transferred to my hospital to fix the bed sore because I created a program, a FLAP program. So we were getting patients from 500 miles away from hospitals, nursing homes, home health, who had serious bed sores, and they were either going to be at high risk of death from sepsis or make it to my hospital for closure.
Back to the question of the bed sores and hospital-related bed sores. I would say rare situation where you've got hypotension that's, in this case, massively low blood pressure that occurs as a result of sepsis. That may be something that could be argued isn't preventable, right? But in the vast majority of cases, a bed sore, a decubitus ulcer, a pressure wound is completely preventable. And it's preventable through good care, through the standard of care in a hospital, and that's turning people, right? Can you explain that, how that all occurs? How are bed sores prevented?
Prevention of any patient who is dependent on others because of illness or injury require manual repositioning to change their side. If they're laying on their back after 2 hours, before 2 hours, they need to be turned on the side. 2 hours later, they could be turned back on their back or the other hip, and that skin observed. It's just routine nursing care, okay, that all nurses are taught. Every hospital should have ongoing education of nursing. Every hospital should be monitoring turning, monitoring the occurrence of bed sores, ongoing education. But we're seeing hospitals now, and we're seeing nursing homes being bought by private equity, where hospitals are
Hedge funds?
Hedge funds, yeah. Private equity is buying community hospitals for profit. They are taking the profit instead of reinvesting in education of nurses and nurses' aides, and people are getting bed sores. And it's what they consider the price of business. So we're suing a lot of hospitals that are owned by private equity now.
Here's my question. How does a bed sore develop, and why does it develop? And get into the minutiae, if you need to, of how it affects the circulation and how pressure affects it. Explain all that stuff.
Yeah,
right?
I got it. So say you are lying on your back and you are not moving, okay, because you're sedated on a ventilator. And you're laying on your back, so you have your sacral bone and the skin compressing because of gravity and pressure from the bed. The muscle is under the skin in between the bone, and the muscle gets pressed. When the muscle is getting pressed or pressure on that muscle, it prevents blood flow. And if it prevents blood flow for too long, the cells lose their oxygen supply, and the cell on an individual basis will die. And if there's a lot of cells, then you're losing tissue, you're losing muscle, and over 2 to 4 weeks, that muscle will die, liquefy, and there will be an appearance of a dead tissue on the skin where the skin will turn black, the muscle is dead underneath it, and it goes all the way to bone. That is a bed sore. That's a stage 4 bed sore, and that's a serious injury. So we have clients who develop these dead areas of their skin, big areas on their sacrum, which is on top of the buttock, or on their hip, or on their heels, and the hospitals are just simply discharging them to a nursing home without a formal plan for getting them to cure.
Okay, so, and that's what I still don't understand. What is the motivation of a hospital having a patient with a bed sore, probably created by the hospital, and then discharging the patient to a nursing home without any plan of care. And I'm talking about a patient that may or may not have even been a nursing home patient in the first place. In other words, someone who walks into the hospital, lives at home, lives at assisted care, and then all of a sudden develops a bed sore in the hospital, then is sent to a nursing home. How does that happen?
The conduct is appalling and unconscionable, that hospitals are sending people to a lower level of care where there is not a pathway to cure. They're getting the patient who they injure off their books because insurance companies will force them to pay for that cost if that patient stays at their hospital and gets care. So these hospitals have a lot of different doctors. They have plastic surgeons, they have general surgeons, they have infectious disease doctors, they have internal medicine doctors, they have orthopedic doctors, all of which are sometimes needed to treat a complex wound, and they're discharging patients to other hospitals that might not have the staff, do not have the program to fix these wounds, or they're sending them to a nursing home where they rarely will even see a doctor with a dead piece of flesh on their body to get infected, to develop septic shock. It's unconscionable. There's no other explanation.
So when the hospital sends a patient to a lower level of care, they've got an ongoing bed sore, it hasn't been fixed, what is expected to happen to the patient?
It's miserable. Okay, these patients are miserable. They have big wounds. They're confined to bed now because they can't. If you have a bed sore in your butt, it's hard to sit on your butt. Okay, and so you're basically in bed, turning side to side, and you're getting wound care with hopes that the wound will over time grow in. For that to happen, a lot of good things have to happen. 44% of the time, when you have a stage 4 bed sore down to bone that's infected, that patient is going to be admitted back to the acute care hospital with sepsis. 44%. 17% of those people who are discharged without a flap die. All conservative care, whatever it is associated with a 17% risk of death compared to flap surgery. Flap surgery, every plastic surgeon in their residency knows how to do flap surgery. It's not that hard. It would be hard for me to do, but plastic surgeons, that's what they do. That's what they're trained to do. And hospitals are discharging patients that they could fix, that they caused injury, to a lower level of care.
Explain what a flap surgery is.
Yeah, so the way you treat a bed sore when you have a big area of dead tissue on a person's butt that is black, you have to get the dead tissue off, okay? That dead tissue is going to start getting infected. It'll get malodorous.
What does that mean?
Malodorous is just a nasty smell, okay? It's horrible, okay?
Well, what causes a bed sore to bring forth a nasty smell? I hate to get specific, but
it's infected with staph, it's infected with gram-negative bacteria. So these wounds have to be debrided. You have to have reliable pressure relief. You could put them on a $60,000 Clinitron bed that will make it so that there's absolutely no ongoing pressure that person will suffer from.
If all of that occurs, can a person get better?
Yes, if a person has reliable pressure relief and the wound is cleaned out, debrided, and there's no infection and there's adequate nutrition, wounds can grow in over time, okay? But that could take months and sometimes over a year. And you have to have perfect care and not get infected during that time. So the standard of care ever since I've been practicing has been to flap these patients, and that is you bring in a plastic surgeon, they move muscle that's next to the wound over that hole, there's redundant skin, and that wound becomes closed. You have a drain there that you keep in place for a couple weeks, and that wound becomes healed. So in 4 weeks after a flap, these patients are generally up in a chair, involved in rehab, okay, trying to get better now. So I'm a spinal cord injury doctor, okay? So I've taken care of spinal cord patients my whole life. And I'm in this small rural hospital that I developed a FLAP program in northern Louisiana. And I was referred a bed sore case from New Orleans, a major teaching hospital in New Orleans, on an African American who developed a pressure ulcer right after injury. And they were trying to rehab him. You know, they had him going through rehab with a bed sore on his butt. That's impossible. If you don't have legs and can't walk and you have a big old sore on your butt, how are you supposed to learn how to transfer from bed to chair to toilet? If you have a dressing on your butt and you have to do pressure reliefs, it's a setup for failure. So this patient got referred to me, my hospital, and they wasted 4 to 6 weeks doing rehab on a spinal cord patient who couldn't be rehabbed. And so he comes to my hospital and he's expecting wound care. And I'm like, you know, I recommend that we close this wound. Okay, we fix this wound and then rehab you. Okay, because he needed more rehab to get independent.
Happened?
Well, we fixed him and he left the hospital as an independent paraplegic man who able to take care of himself without a wound. He didn't have to go home with home health, go side to side. It's kind of common sense, isn't it? You fix the wound, and that's the standard of care. It's been the standard of care, and now since 2023, the national guidelines say that these wounds should be closed, finally.
Okay, I want to get a little bit even more granular, right? So what is a bed sore?
A bed sore is a area of dead tissue caused by pressure. So the muscle dies first if a person is not reliably turned. If the muscle dies, then the skin will die because it loses its blood supply, which comes from the muscle. And over 2 to 4 weeks' time, that skin will become dead. And eventually you could put your fist in or 2 fingers into the wound because it's a serious injury.
Are there different names that medicine uses for a bed sore?
Well, bed sores are called bed sores, decubitus ulcer, pressure injuries. They're all the same thing.
Pressure.
Yeah, they're all, and we call them never events, okay? And it indicates that the nursing care was bad. If there's bad bedside care, then there's other problems in that hospital that are likely, because what happens at bedside is by far the most important thing that occurs with a patient, because if a patient's not being turned, that means that nurses are not going in there to assess the patient. If they're not being assessed, then doctors aren't being notified of medical changes. So it's usually the tip of the iceberg.
What type of patient would be subject to development of a bed sore? Like, let me ask you this question. Someone will walk into a hospital and they're there for a surgery. They're a young, healthy person. They're going to be in the hospital for a couple of days and be released. Are you expecting that patient might become subject to a bed sore?
Any patient who, because of illness or injury, has a period of time, generally it could be as little as a day, that they can't provide their own turns. They need to be turned because bed sores can occur. We have serious bed sores on patients who go in for elective knee surgery, for knee replacement surgery, okay? That they walk into the hospital, they have knee replacement surgery, they have a difficult rehab, and because of pain, because of other complicating factors, aren't able to turn. And we have a wrongful death in Texas on a knee replacement, a patient and an elderly person who got a bed sore. You know, so this happens to anyone because of illness or injury who cannot turn themselves. So I'm a rehab doctor. I take care of spinal cord patients. I take care of brain injured patients. I take care of people with amputations, catastrophic orthopedic injuries, people who have heart attacks, strokes. My whole population was at risk for bed sores. So in terms of prevention, monitoring, we were on it. Okay, so during my clinical practice, there were 2 patients of mine who developed bed sores that required surgery, surgical intervention to cure. And in both of those patients, I did not allow them to be discharged until I figured out a path to get them fixed. And I found a surgeon in the community to help me. And I kept that patient in my hospital and I had them fixed, and then ultimately developed flap programs after that. So they can occur. It happens when nurses aren't doing their jobs. And, certainly in those situations, people are held accountable for their failures.
What about physician liability? Just meaning, so when I say liability, I'm asking, what about a physician's responsibility for a bed sore? Are the physicians ever responsible?
Yes. So in terms of, there's 2 parts. So in terms of causing a bed sore, generally that's indicative of nursing care, because the doctors aren't there turning a patient, okay? But we are seeing hospitals and in nursing homes where a person is developing a bed sore and a doctor is notified and the doctor never actually looks at the wound and is deferring treatment to the nursing staff. If you are the attending doctor, you need to look at that wound, you need to stage that wound, and you need to make sure that patient is safe. We're seeing hospitals who now own or employ hospitalists. So a hospital causes a bed sore, their hospitalist who they employ doesn't assess the wound. They provide ineffective care, and then that hospitalist signs the discharge order having them go to a lower level of care. We're suing those doctors, their employer, which is the hospital, the nurses, and the hospital. So there's failure to prevent and a failure to treat, and then there's the unsafe discharge. Brutal story, isn't it?
Brutal.
So if you've suffered a bed sore, we are prosecuting these cases across the country. We have experts, plastic surgeons, general surgeons, orthopedic surgeons, nursing home administrators, hospital administrators, infectious disease doctors, nurses, nursing experts, and so we're prosecuting these cases across the country.